We shouldn't have a problem. Ashok is with us. I mean, this guy is a veteran of
Manish sir, we are live now.
1,000 webinars.
Okay, we are live now.
We are live.
Good evening, everyone. Good evening. And I welcome all the faculty, especially Professor Rajesh Malhotra and Dr. Sudhir.
Ashok is with us. I mean, this guy is a
Dr.
veteran
Maggu.
Manish sir, we are live.
1,000 webinars.
Please, Gurinder, we are live now.
Unmute.
Yeah. Good evening, everyone. I welcome Professor Rajesh Malhotra, Dr. Sudhir Kapoor, Dr. Maggu, Dr. Lalit Mani, Dr. Sumit Sural, and Dr. Gurinder Bedi. And from DOA, I welcome Dr. Sharad, Dr. Hitesh, Dr. Dhananjay, Dr. Harmesh Kapoor, Dr. Vineet Arora, and Dr. Rehan. So I welcome you for this first DOA, Delhi Orthopedic Association PG training program. So first module is the hip joint. We will have a specific module every week. So next week is spine. So this for this session, it is the hip joint, and we have all the known stalwarts. So we start our program, and I request Professor Lalit Mani to come up and share his screen for for history taking in hip joint. Professor Lalit Mani. Professor Mani will, shortly explain that how to take the history in a hip case.
Is the slide visible?
Yes.
Good evening, everybody, and thank you, Ortho TV, Manish Dhawan, Delhi Orthopedic Association. I think it's an excellent idea of doing these webinars. Today's topic being hip. We start with the first talk, which is on history taking in a hip case, and I would start with this quote of William Osler, which says, "Medicine is a science of uncertainty and an art of probability." I think this stands amazingly true in these difficult times of the pandemic, when it is a science of uncertainty and developing into an art of probability. One of the most important cases, the hip case, every 3 out of 5 candidates get hip as a long case usually. And the interesting part of hip evaluation is that it actually trains a postgraduate into the various parts of evaluating a patient, and that is why it becomes such a important part and is taken as a long case. So history taking in a hip case would, as in all other scenarios, would move around these pillars, which are patient data collection, the presenting complaint, the history of present illness, past history, the treatment history, and the social history. So you move from the patient data and end your history taking with the social history. This is actually similar in most parts, and each component of these would be slightly different in each part which you're evaluating. So let's try and understand each part separately in a bit of a detail. And I will assure there's going to be a lot of repetition about what you need to do in this. So history taking, it is as important as examination. Should be thoughtful, systematic, and comprehensive. Usually by the end of history, one should be able to conceptually bring forward a bunch of probable diagnoses or what condition we're dealing with. We need to have some amount of differential diagnosis in our mind, 1, 2, 3. It is usual for an examiner to ask at the end of the history, what is in your mind after getting this history? Be prepared for it. So starting with demographic data, this is a normal thing which you do day in and day out. but at times we miss out a few important things. So there's an interesting mnemonic for this, Nasomra. N is for name, A is for age, S is for sex, O is for occupation, M is for marital status, R is for residential address, and A is for admission date or when the patient came to you. So if you have such mnemonics with you, the probability that you will miss out will be less. And it's not a bad idea when you start your practice of taking history to stick certain mnemonics which will help you. Now, maybe all have bearing on the diagnosis as well as management of your patient. Like for example, sickle cell disease normally come from belts which have higher incidence of sickle cell disease. So maybe it correlates with the diagnosis of AVN. Certain sex are more related to certain diseases like bad arthritis and ankylosing spondylitis. Age, you very well know, Percy's disease, SCFE, EDH, they would have a particular age when the patient comes to you. And occupation, of course, is going to tell you something about what could be the disease, and it will help you on deciding upon the management. So the starting point after the demographic data is the presenting complaint. We have to be very clear and crisp about what is the presenting complaint, and we need to present it in a chronological order, meaning the complaint which came first, for example, pain in the right hip for the last 3 months and limp in the right lower limb for the past 7 days. So whatever complaint comes first, it should be told first with the number of days or months, and whatever complaint came next comes next. So the presenting complaint has to be very clear and should come with the duration. So normally it is in the patient's own words. And if you take a hip case, the usual complaints in a hip case are pain, swelling, limb, inability to bear weight, limitation of movements, deformity or a limb length discrepancy. Complaints to be mentioned in the order of occurrence of the chronology I have explained, and then you go ahead describing each complaint on the broad base of onset, duration, and progression. So ODP could be another mnemonic. So history of presenting illness, how do you get it out? You ask the patient, when were you absolutely okay? You actually have to take him back to a place, to a timeline where he was absolutely okay, so that he can actually juggle out and actually tell you the right amount of duration he's been having that illness. And after that, you need to ask him what happened then. But then there would be some patients who would come out with a history, I have been ill for the whole of my life. So you need to be juggling around with these patients, and maybe at times you need to ask them what has brought you to the hospital today if your problem has been there for ages. So you have to modify your questioning at times, which have to be straightforward, or at times you have to encourage the patient to speak out. So the common complaints around the hip. Now this part we're going to repeat two or three times in the next 10 minutes. Pain, which is going to be the most important. Swelling. Function loss. Now the function loss could be in standing, maybe on both feet or one limb. In walking, it could be in sitting, chair, squatting, or cross-leg, or it could be in lying down. And then the patient could come with a presentation of a deformity. So what do we need to describe about each symptom? We need to describe on the onset, the course, the duration, any treatment taken or given, and what has been the response. So the broad outline for each symptom would be on these grounds. But in pain, there would be certain addition things. We are more interested in understanding what is the exact site, the character, the intensity, and radiation. So normal symptoms, you want to know the onset, and you want to know the duration and the progress. But in pain, you want to know certain more things. So another mnemonic is there to help you, which is by the name of Socrates. So each word means something. S for sight, where is the pain? O for onset, when did the pain start? And whether it was sudden, gradual. The character, what is the pain like? Is it stabbing or throbbing or dull aching? Radiation, does the pain radiate anyway? Association, any other sign or symptom which is related to this pain? Time, the course, does the pain follow any time duration? Exacerbation and relieving factors, does anything change the pain? And the last thing, the severity, how bad is the pain? So Socrates is one of the good mnemonic to remember so that you do not miss out any of the features related to pain. So something more on pain or different perspective. This being the commonest symptom in a hip case, the side, is it left or right, or is it bilateral? In case of bilateral, is it symmetrical or one side is more painful than the other? The side, where exactly is it? The patient pointing towards the groin, is it on the lateral side or is it on the gluteal area? The onset, sudden insidious onset, or the patient is not clear on the onset. Duration, and is this duration related to remissions and relapses? The severity, mild, moderate, or severe. The character, dull, sharp, throbbing. Radiation, time, is it continuous? Is it intermittent? Or is it activity related? Is there a diurnal variation? Is night pain a very, very prominent phenomena associated? What are the aggravating factors? Does movement increase the pain? What are the relieving factors? Invariably rest, medication, these are two commonest. Progressive over time. Is pain progressive over time? What is the present status of the pain and what disability is it causing? So the severity, progression, present status, and disability it is causing can objectively be shared from the patient by sharing the visual analog score or asking him to score it from 0 to 10, which will give you some objective idea. It might not be very easy for many patients to come out with it, but if you try it, it gives the clinician a very, very objective way of understanding where he's moving. Now, the side infective disorders like TB hip, septic sequelae invariably are unilateral, inflammatory could be bilateral, AVN if post-traumatic could be unilateral, if it is maybe steroid related can be bilateral. So all these features are going to take you towards what is the diagnosis in a patient. Site, very important, invariably it is the anteromedial groin plane, which the hip produces, and be careful if it is a gluteal pain. Better check up on the spine and the back and be sure that the pain is coming from where. The next important symptom would be a limp, and we want to know the onset, we want to know the duration, we want to know whether it is painful or painless. Now this one association separates the diagnosis into two groups. A painful limb and a painless limb gives you a different list of diagnoses. And if you broadly divide it, invariably childhood limbs are painless and invariably adulthood limbs are painful. This is a rough sort of a assessment. Progression over time, what sort of a walking does the patient have if he has a limp? Does he need assistance? Is it an assisted gait or he's still continuing unassisted? Or he's just not able to walk? At times, limp could be the first symptom in TB hip even before pain. And as I've already told you, a painless limp is a very, very common presentation in the pediatric hip. Next symptom, which might not come out from the patient straight away, unless you probe and sort of get it out, if your history is pointing towards such a thing. A swelling, we need to know the side, and the side We need to know the onset in relation to the other symptoms. We need to know the duration, whether it is painful or painless, whether it is associated with a scar or a sinus, and what is the progression over time, and what is the present status. So the ODP continues in the various symptoms. So in similar way, history about each symptom should be elicited and noted. And with each symptom, you want to know, and invariably the patient has taken some treatment. So you need to end up each symptom details description by what treatment he has taken. Like one example I've written down here is that for these complaints, patient took treatment from a local medical practitioner and got treatment for in the form of oral medications, tractions, but got only partial relief of his symptoms, so he consulted this hospital 4 days back. So you need to summarize some amount of treatment given with the presenting complaints. Remember, the presenting complaints with a hip case are not going to be many. And then finally, you need to summarize in maybe one line on the current functional status of the patient. One example could be, at present, the patient is walking with the help of walker only at his home. He is unable to attend to his occupation. He is able to sit on a chair, but unable to sit cross-legged or squat. So it gives you a bird's eye picture of what sort of a functional status the patient is having on the basis of history itself. And then the negative history, recent significant trauma, fever, the type of fever, cough, contact with the TB patient, whether the patient has a morning stiffness, whether he has other joints involved. So depending upon the symptomatology, you would like to present a negative history, which will actually support your diagnosis at the end of the day. So next comes is the past history. You want to know something about similar episodes of these symptoms in the past. You want to know any associations of other symptoms, of other systems, whether it is CVS, whether it is respiratory system, whether it is abdominal. And you can just, in your mind, look for symptoms from head to toe and ask the patient if they might have an association with your presenting complaint. So you want to have a past history of trauma, surgery around the hip, long treatment undertaken, any history of tuberculosis, any dermatological disease for which the patient might have taken steroids, any long hospitalization, or any surgery for any illness. Then comes the social history. It has two parts to it, the personal history and the family history. The social history aids you in the diagnosis as well as discussing the treatment with the patient once you have come to a diagnosis. So in the personal history, again, I will take this quote from William Osler. It is much more important, he says, to know what sort of a patient has a disease. He's assuming that you would know what sort of a disease the patient has, but he emphasizing that you should know what type of a patient you are dealing with. You need to know his personal details, commonly the diet, the alcohol intake, smoking, any other addictions, and females, the menstrual history. The family history of any significant illness in the family or any similar disorder. You have to take a history of tuberculosis contact, any inflammatory arthropathy in the siblings or the parents, any metabolic disorders or hematological disorders. Family history is also important to understand what support system the patient might have to you to decide upon what sort of treatment you can offer him. So you're almost through your history cycle, and be ready with this. The examiner might ask you, or even yourself when you're looking at a patient in a clinic, you want to come to some provisional diagnosis at the end of the history. In an adult, it could be an ankylosis, it could be an arthritis or a synovitis, it could be a post-traumatic situation or any other thing. Without something in your mind. In the exam, you might be asked about, or you might not be asked about what is the causative part of the provisional diagnosis. And I would request, don't jump to a very, very specific, detailed diagnosis on the history base itself. A common diagnosis could be a fibrous ankylosis in an unsound position, maybe an infective etiology. But don't spell out a very, very specific diagnosis, because that is actually not possible with just history. So summarizing at the end, you need to take the patient data, you need to have the presenting complaint very clear with the duration, the history of illness on the onset, duration, and the progression, past history, treatment history, and the social history. So this is a broad plan which I have shared. You might have to add, delete, or change the plan depending upon what case scenario you're dealing with. There would be many other parts which need to be a part of your history, which will actually build up during this 2-hour symposium when we are talking about specific case scenarios in the subsequent lectures. One good habit could be, as we make notes whenever we go through any topic we read, most institutes have their own hip performer. You might develop one of your own and then practice your history taking on this, so that it becomes a very, very automatic phenomena for you yourself when you go ahead doing it in the exam. So to end, I would like to share this slide, which is a very, very common practice I do. I divide my OPD's sheet into 4 boxes. The first box is history, the second is examination, the third is investigation, and the fourth is treatment. And that is how we manage our cases, and that is how this symposium is drawn to give you knowledge about a hip case. Thank you very much.
Thank you, Professor Mani, for a very nice history taking lecture. Now we will take questions for 5 minutes. And is Dr. Vineet? Dr. Vineet?
Dr. Vineet has not yet, sir.
Okay.
Yes.
So,
Yeah, I'm there.
Yeah, Dr.
Yes, I'm there.
Please proceed with the
Sir is
question.
there. Sir is
The
there.
teaching coordinator. You have
Can
any
I
questions?
stop my screen share?
Yeah,
Yes, stop
I
your
could.
screen share.
Yeah,
Dr. Vineet, you are
I'm-
visible, sir.
yeah. I'm just waiting. Kids, some of my PGs are supposed to give me a call. I'm just waiting for them on the
No,
WhatsApp.
you can discuss. You can ask questions in regard to the postgraduates. You can start asking the questions.
Vineet,
All
can I
right.
ask a small clarification?
Yes.
Uh, Dr. Mani,
Yes.
right. Thanks for very thorough disposition of history taking you have given us. Just very small basic clarification I want. You said when you're starting your history, you speak about the oldest symptom of the present illness first. Isn't it the other way around, that you speak of the latest symptom and then go to the oldest of the present illness?
Actually, if you go historically, history is about starting from where the patient was absolutely well. So you ask him, when were you absolutely well? And then you ask him, what went wrong?
Sorry,
So
about the
that is
present
what is the convention is. You start with
I'm
what
saying.
went wrong, and that is what you sort of label first. I'm not sure whether there are other conventions. There's no big deal about putting it the other way around also. But the convention is whatever symptom has stayed the longest, because that is where the patient starting having his problem. That is where he's answering his question.
But
That
presenting
what
complaints, presenting complaints. When you speak of presenting complaints, at that time I was just clarifying.
yeah.
Okay. And any other question from the panelist? Any other question, or we go to the next lecture? And once I receive questions from the audience, I will keep on asking. So I request now. I think there are no questions at present. So I request Dr. Sudhir Kapoor to come and give his presentation on examination of the hip joint. Dr. Sudhir Kapoor.
PPT is visible now. Can you see it?
Yeah, sir, you are visible, sir.
My PPT.
No, sir.
Please share your screen.
I thought I shared it.
Sir, please open the PPT separately, then the Zoom.
Okay.
First, minimize the Zoom, sir.
Give me a minute.
Yes, sir.
Minimize, but it's showing in a window separately.
Yeah, sir. And
Now I'm opening the PPT is visible now.
now open the PPT on the desktop, sir.
Yes, I opened the PPT.
Now move to the Zoom
Share with us.
and click the sharing. Share screen.
Okay. Share screen. Okay.
Bottom down.
Is that okay? Fine, sir.
Yeah. Got it, sir.
Yeah, now better. Now.
Can you
Yeah,
see
nice.
it now?
Yeah, sir.
Okay, then can I start?
Yeah, sure.
Yes, sir. Yes, sir. Please
Ashok, the
start.
PPT is
Friends,
covered by a lot of pictures. Can we get the faces of the faculty away from there?
Yes,
Sir,
that's better.
you can do it. On the top, there are 4 boxes,
Okay,
multiple
got
windows.
it. Yeah.
Just click on the single window, sir.
Okay.
Single window. Single
Okay,
window.
please start.
Okay. Fine, sir. Can I start now?
Yes, sir. Yes, sir.
Well, at the outset, I must thank the organizers for this excellent program. And I think Lalit has given a wonderful exposition of history taking. So let me take you to the examination of the hip joint. Well, friend, you must have heard all this thing, that a thorough clean examination is required. Most of the teachers must have told you this. But as far as I am concerned, please understand that sequence is the most essential thing. If you follow a particular sequence throughout your career, throughout your training, you will never miss a finding during the exam. So as far as I am concerned, thorough clean examination, fine. But sequence is the single most important thing as far as I am concerned. Well, there is the sequence is, as you must be seeing on your screens, about inspection, palpation, movements, deformity, measurements, and special tests. I'll proceed according to this plan only. Well, I'll not go into any details of the gait since Dr. Sumit is already covering it. I'll simply, since it is a relevant thing, I'll simply mention these are the important gaits which are pathological gaits which happen in the hip joint disease. I'm not discussing any details, just a few seconds clips with the catch frame for everyone. Now, this is a antalgic gait. The gait with the reduced stance face. No further discussion. I think Dr. Sumit will cover it. 10 number gait, lurch on the affected side when it is in the stance face. Then short limb gait, up and down movements of the on the short limb side when it is in the stance face. And in a short limb gait, it is not unusual to find one or two elements of pathological gaits combining. Like in this patient, the short limb plus 10 number gait. I don't think I'll discuss anything more about the gait. Now, this 10 number test, the 10 number test sometimes it is included in the special test. But I think it's not a bad idea that before you ask the patient to lie down, to conduct this test, to make the thing simpler for the patient and for you also. Now, this is the example of a normal situation when the patient is standing on both the sides. Everything is on the level. The procedure, I mean, you are supposed to examine the patient from the back, appropriately undressed. This is a child, so it is completely dressed, otherwise appropriately undressed. And you are supposed to see the level of the posterior sphenoid spines and the gluteal folds while inspecting from behind. In a normal situation, when the patient stands on one side, the other side posterior sphenoid spine rises a little, and the opposite side gluteal fold also rises a little. This is a normal situation. What happens when there is a abductor weakness because of the hip joint disease? This is what happens when hands on the affected side, the opposite posterior superior iliac spine, instead of going up, it goes down because the abductors are weak on this side. The abductors are weak on the right side. So when the patient stands on the right side, the left-sided posterior superior iliac spine, instead of going up, is going down, and the gluteal fold is also going down. Gluteal bulk or gluteal fold is also going down instead of going up. This is a classical Trendelenburg sign. The next video shows you how to examine a patient with this test. As I told you already, you must examine the patient from the behind. Ask the patient to show his back towards you. Ask him to first stand on the sound limb. This is a normal situation. His left lower limb is normal. That is why the right upper limb, right gluteal fold is going up. Now, once he stands on the right side, the left gluteal fold goes down. The left superior iliac spine tends to go down, and patient lurches on the right side. This is a classical Trendelenburg sign. Now, there is some test called assisted Trendelenburg test. If a patient is unable to stand on single leg stance, the examiner may provide him assistance to stand. Now, this patient has got a weak abductor mechanism on the right side. He is not able to stand on the right side. So we are conducting a assisted Trendelenburg test in this patient. First is asked to stand on the normal side, which he is able to do nicely, no problem. The moment we asked him to stand on the affected side, that is the right side, he puts extra weight with the help of his left hand on the patient's right hand, on the clinician's right hand, and only then he is able to stand. Please notice that the patient is putting extra weight on clinician's right hand side with his left hand. This is assisted Trendelenburg test. Now, after we have seen the gait, we have conducted the Trendelenburg test, then we come to the attitude of the limb. We are going as per the plan which I had shown you earlier. Well, one can make out that the limb may be in a normal position. You can see that in the first picture, the patient's right limb is in external rotation, while on the other picture, the limb is in internal rotation. So attitude of the limb should be noted by the clinician. Now, this is a typical example of attitude of the limb when there is a posterior dislocation of the hip joint. There is flexion, there is adduction and internal rotation. You can see the X-ray of the same patient with the typical attitude of the limb. Now, inspection, once you have done, once you have seen the gait, you have seen the Trendelenburg sign, you have noted the attitude of the patient. Now come to the inspection on standing from the front. These are all the points which one is supposed to mark when examining the patient while standing from front. I'll give you a clinical example. This is a patient who has got a disease on the right side. Once you are inspecting from the front, make a note whether the head is central or not, whether both the shoulders are on the same level or not. In this patient, right anterior spinal spine is at a lower level. Right patella is at a lower level. Please make all these observations while inspecting the patient from the front. Then you inspect the patient from the side. On the side, the things which are to be noted are what is the state of the lumbar lordosis as far as the hip joint disease is concerned. Like in this patient, there is increased lumbar lordosis and the right hip and the knee are flexed. As you notice, the patient has been adequately and decently undressed to examine. Now we go to the inspection from the back in the standing position. Once we are conducting the inspection from the back in standing position, all the points should be properly marked. The posterior spherical spine, the spinous processes, the gluteal bulge, gluteal folds, and the back of the thigh should be visible to you. And you can make these observations. Like in this patient, the head is central, both the scapulae and the shoulder are symmetrical. Right posterior spherical spine is at a lower level. Now this was the inspection in the standing position. From that we go to inspection in the supine position. Like in this patient, once the patient is lying down, please make note of the level of the anterior iliac spines on both the sides. In this patient, the right anterior iliac spine is at a lower level, the right lower limb in the external rotation. And similarly, now you can examine you can inspect the patient in the lying down position. When you are inspecting the patient in the lying down position, make sure that the patient is lying on a firm bed with a firm mattress. Make note of you must mark the anterior spherical spine as well as the iliac crest. Make note of any exaggeration in the lumbar lordosis. Take note of the trochanteric region and the lateral thigh mass. This is summary of the inspection. I'm again repeating the points which I have covered. I have told about the gait, then attitude of the limb, then inspection from the front, from the side, from the back. This will be the summary of inspection. Now comes the palpation. Once you are inspecting, please make note of any redness, any scars, any sinuses, any muscle wasting or any ulcers. Now the different points to be covered, different steps to be done when the palpation is concerned, palpation is done. The first point, doing palpation anywhere in the body or any system of the medicine is concerning tenderness. As far as the hip joint is concerned, we are concerned basically about the anterior hip joint tenderness. The hip joint tenderness anteriorly is felt or palpated just 1 centimeter below and lateral to the position of the femoral artery. Another type of tenderness which is noticed in patients of hip joint disease is about the bilateral pelvic compression test. We are doing whenever there is a disease which is affecting the central portion of the hip joint, the pelvic compression test will be positive. Now there are other uncommon sites for tenderness pathology. Tenderness in different pathologies of the hip joint. Sometimes there may be a tenderness along the origin of the adductor longus, insertion of the ilius psoas, or there may be the tenderness at the trochanteric bursa, or origin of the hamstrings may be tender at the ischial tuberosity. But basically, we are concerned with anterior hip joint tenderness and bitrochanteric pelvic compression test, which will denote central tenderness. Continuing the palpation further, always palpate the iliac fossa. You may find a cold abscess there, or sometimes in cases of protrusio acetobuli, when because of the disease the acetabulum has protruded inside, one may be able to palpate the protruded acetabulum from the iliac fossa if the patient happens to be a thin patient. Now there is something called digital three-finger palpation. Though Bryant's didn't describe it, sometimes it is known as a digital Bryant's triangle. With the help of the 3 fingers, with the thumb on the anterior superior iliac spine, the index finger on the tip of the trochanter, and the middle finger at the perpendicular going from the anterior superior iliac spine to the floor. This is how the triangle is made, and one is supposed to make triangles on both the sides to compare. One can make out on palpation whether the trochanter has ridden up or not. You must palpate, continuing the palpation further, you must palpate the possible sites of cold abscess, which could be the base of Scarpa's triangle, gluteal lesion, supratrochanteric region, iliac fossa, which I have told you already, and anterior medial aspect of the mid thigh. This is a summary of the palpation. Basically, it is the tenderness, the local temperature. The tenderness I have told you already, anterior hip joint tenderness or about the bitrochanteric compression test. You must make a note about the palpation of the trochanter, whether it is hard to touch, whether there is any roughness, or whether there is any crepitus felt during palpation of the trochanter. We have already palpated the femoral artery to locate the point of anterior hip joint tenderness. At the same time, either this test can be done in the last, or at this juncture also you can compare the 2 femoral pulses and see if the hip joint you are examining, whether it has weak pulses compared to other hip joint. If the hip joint you are examining has either weak or absent femoral pulses, then Bosco sign on the Rath is positive. Then I've told you about the distal Bryant's triangle, or basically trying to palpate with the help of 3 fingers and trying to find out whether trochanter has gone up or not. Then I've told you about the sites of palpating cold abscess, and of course Trendelenburg sign we have done earlier. Now deformities, assessing the deformities in the hip joint disease is an integral part of the palpation. And to define a fixed deformity in hip joint would be a fixed deformity is defined as a position of the limb from which it cannot be brought to neutral or zero position for that axis but further movement in their axis may be possible. For example, if the patient has got a 70-degree of flexion deformity, extension will not be possible, but it may be possible that the patient has got some more flexion beyond 70 degree. This is what is meant by a fixed deformity. Now, this is about a person who has got a hip joint which is deformed. A patient cannot walk unless the body compensates. In a case of fixed flexion deformity, the compensation occurs by increased lumbar lordosis. In ambidextrous deformity, the compensation occurs by drop of ipsilateral anterior spherical spine and lower lumbar spine scoliosis with ipsilateral convexity. In ambidextrous deformity, there is elevation of the ipsilateral anterior spherical spine and scoliosis with contralateral convexity. If you want to measure the exact amount of deformity, one must unmask the true degree of deformity by neutralizing these compensatory mechanisms. That is the basis of assessing deformities in the hip joint disease. Now, fixed flexion deformity can be assessed by the Thomas test. The next video will show you how to do a Thomas test correctly. The patient is lying on a hard bed with a firm mattress. One can inspect and confirm by putting the hand whether the lumbar lordosis is increased or not. Like in this patient is increased, then the opposite hip is flexed. After the hip is flexed to a certain degree, the increased lumbar lordosis starts to obliterate, and at one point it obliterates completely, like in this patient. When this happens, the hip joint goes into the flexion deformity. Confirm by pressing on the thigh whether the limb has gone to exaggerated lumbar lordosis or in the exaggerated flexion deformity, and then measure the exact amount of flexion deformity as shown to you. Every step is important. Now, if you want to know what is the range of flexion in a case of fixed flexion deformity, basically, is there any flexion possible after fixed flexion deformity or not? Then this is a method to do this. Please see it carefully. First, the Thomas test is done in the same manner which I have shown to you. The normal hip is flexed. The flexion deformity becomes obvious. Just press to counter for any increased flexion deformity. Measure the flexion deformity. Then with one hand holding the lower thigh, one can flex the hip further, while with the other hand one feels any movements of the pelvis. Once the pelvis starts moving, that is the point till which the flexion is present. So like in this patient has a fixed flexion deformity of 60 degree or so, and is almost further flexion is possible till about 80-85 degrees. So he has a free range of about 25 degree or 20 degree of free flexion after the fixed flexion deformity. Now there is a situation called a pseudo flexion deformity. Sometimes the disease is not in the hip joint, but there is a irritating lesion in the vicinity of the hip joint, which is forcing the hip joint into pseudo flexion. Now this is a patient of a pseudo flexion deformity because of a psoas abscess. Now how to differentiate a pseudo flexion deformity from a true flexion deformity? Please see this video carefully. In a case of pseudo flexion deformity, when the disease is not in the hip joint, the rotations will be free and painless. In this patient, rotations are free and painless. If the patient had hip joint disease, the rotations would have been painful. At the same time, in the same patient, if we try to do the Thomas test, the child cries. This is a typical example of a typical case of a pseudo flexion deformity, in which case hip rotations will be free and painless. Now, how to measure if a patient has got a bilateral flexion deformity of the hip joint, how to measure that? This is the classical method. This is a classical method. The patient is made to lie prone on the examination table. Both the hips are flexed, which will obliterate the lumbar lordosis. Now the one hand remains on the lumbar spine. The other hand extends the hip gradually. At the point where the hip joint, the lumbar lordosis starts reappearing, is the amount of flexion deformity of that particular hip, measured in this manner. The same thing is repeated on the other side. Now this method becomes sometimes impractical if the patient happens to be an adult and heavy. In that situation, I think I have described a new method of testing flexion deformity of the hip joint in cases of when there is a bilateral hip involvement. The patient is made. I think this is I have not found this method in the literature, and I feel that I'm the first person to describe it. In this patient, in this case, both the hip joints are flexed till the time the lumbar lordosis disappears. The one limb is held by an assistant, while the other limb is gradually extended. At a certain point, the lumbar lordosis starts reappearing. One can measure the flexion deformity in this manner also. The same thing is repeated on the other side. Now, how do you measure a fixed ambidextron deformity? We are talking about deformities. We have seen how to measure fixed flexion deformity. We have seen what is the normal, what is the range of flexion beyond flexion deformity, and how to measure bilateral flexion deformity of the hip joint. Now we come to the adduction deformity. How do we measure the adduction deformity? As I told you earlier, we have to unmask the deformity. In a case of ambidextron deformity, unmasking is done in the manner shown. Now this patient has got a ambidextron deformity on the left side. The deformity is unmasked. The anterior spherical spine was at a lower level. The limb is abducted till the two anterior spherical spine becomes square. And then the amount of ambidextron deformity can be measured. Now, there is one more method of measuring ambidextron or adduction deformity by Kothari's angle. In the previous method, which was described by Nelson, also known as Nelson's method, we had to square the limb. While in the method described by Kothari, there is no need for squaring the pelvis. In whatever position the two anterior spherical spines are, one line is drawn to join the two anterior spherical spine. Then a perpendicular is drawn from the anterior spherical spine to the midline, another from the anterior spherical spine of the left side to the midline, as shown in the diagram. In a case of ambidextron deformity, this will be the angle of deformity. The angle formed below the line joining the anterior spherical spine. In a case of adduction deformity, it will be the angle above the line joining the anterior spherical spine. So in this Kothari's method, there is no need to square the pelvis. Now, how to measure fixed adduction deformity? Same principle is followed. The adduction deformity is unmasked by squaring the pelvis, as shown. The anterior spherical spine was on a higher level. The limb is moved to adduction, and the pelvis has become squared now. One can measure the deformity in this manner. So square the pelvis and measure the deformity as shown in the method.
Dr. Sudhir, please be slightly fast.
Okay, dear. Further range of adduction, the same principle as flexion and as in the flexion deformity of the hip joint. Unmask the adduction deformity and see for any further possible adduction. I will not run this video because of paucity of time. Then measure the fixed rotational deformity, which can be gauged by seeing the position of the great toe, direction of the great toe, or by this method in which two lines are drawn. One is a plumb line, another is the line which is towards the roof from the center of the patella. This is a summary of the deformities. movements we have to see. I'll just make a mention of this Dunham sign. This has been there have been several names for this sign. Basically, this is a sign in which in which this was classically described in old the slipped capital femoral epiphysis, but it's been described in now in avian also. In which case, when we flex the hip joint at particular point, the flexion stops, and further flexion is possible only if the hip is taken to external rotation. Let us see. Further flexion possible only if the hip is taken into external rotation. Fine. These are all the movements you are supposed to see. These are summary of the movements. Now we come to measurements. Measurement to be true measurements and the apparent measurements. Apparent measurements are in the whatever position the patient is lying. From any central point of the body, we measure till the middle malleolus without squaring the pelvis. In the two length, we square the pelvis by I had shown you the method already by how to square the pelvis. We square the pelvis and then measure the two length. Like in this patient, I'll show you one example only. In a case of abduction deformity, this is the apparent length. It is measured the limb is squared now. And the length is measured. The opposite limb, which was a normal limb, must be taken into similar degree of abduction to measure the two length, which is being done now. Now you measure deformity. I think I'll rush through the rest of the presentation. Now this sign will tell you grossly whether there is a shortening of the limb or not. The patient lies supine, hip is flexed to 60 degree in the knee, affected to 90 degree, and look for the level of the two knee joints. If there is a shortening, the affected knee joint will be at a proximal level. In a case of femoral shortening, a branch triangle is drawn, as I've told you already, by joining these 3 points: anterior sphenic spine, the tip of the greater trochanter, and the anterior sphenic and the perpendicular is drawn to the bed, and then we measure all the 3 limbs. Like there's a base of the branch triangle in a patient on the left side, same patient on the right side, you can see the shortening. This is a method of measuring qualitatively, not quantitatively, qualitatively the supratrochanteric shortening with the help of the Nettles line. The patient lies on the side, the affected side of the hip is limb is the hip and the knee are flexed, and one sees the level of the trochanter, whether it is at the same level of the line joining the anterior sphenic spine, the ischial tuberosity. This is a normal situation. In a case with a supratrochanteric shortening, the trochanter moves up. This is another method of seeing whether there is a shoemaker's line, whether the supratrochanteric shortening or no not. The line joining the typical greater trochanter anterior sphenic line is sphenic spine is extended further to the midline. If there is a supratrochanteric shortening, these 2 lines will intersect on the opposite side and below the umbilicus. I think I'll leave this. These are summary of the measurements. These are the special tests. I'll not tell you the details. Only 2 tests are important. This is a telescoping test. If the hip is unstable, this is how the telescoping test is done. And this is about how to measure the hip anteversion. This is the last slide. This I mean, you want to see whether what is the anteversion of the hip joint. The patient is lying supine. The the hip is extended and the knee is flexed. Knee is flexed. In that position, hold from the ankle with one hand, while the other hand palpates the trochanter. Find the position of the limb in which the trochanter is most prominent. In that most prominent position of the trochanter, measure the angle made by axis of the tibia with the perpendicular. This is the angle of anteversion. I think I'll finish here. In the last one, must make a note of the lymphadenopathy and the contralateral hip and knee joint. I think I'll finish here. And basically, I've given you a glimpse of what is the full presentation of the hip joint disease. If anybody is interested, then this is my book is available by serious publishers. Thank you so much. Sorry, Manish, if I've taken a lot of time.
No, it's okay, sir. So thank you, Dr. Sudhir. I request Dr. Sumit Surul to be ready with his presentation. And you will get 10 minutes time. By the time you are setting up your screen, I'll just ask some questions from the audience. So one question for Professor Lalit Mani. Dr. Lalit Mani? Dr. Lalit, can you hear me? Dr. Lalit?
1 minute, sir.
Yes.
Lalit, sir?
Yeah, Professor Mani, there is a question from the audience. Now he says that if a patient presents with a complaint of pain 6 months back for 10 days, followed by relief with medication, and an asymptomatic period of 6 months, followed by pain again in similar character and at the same site with no trauma to the site for 1 week, would history of present illness date back to 6 months or start from 1 week?
So I think the guiding principle which says that you need to ask the patient, when were you well? That is one of the guiding principles to how you present your history. So once the patient says that he was not well 6 months back, and then he had an episode of a problem for a few weeks, got well, and then episode of problem, got well, and then he could have even fallen down and had a significant trauma. But this is where the history is telling us in a very subtle way that probably the disease was there 6 months back with the pain, and then the pathology has caused weakening of the bone and he's got a fracture. So according to me, you need to be very clear when were you absolutely fine regarding your hip problem, and that is where your presenting complaint starts.
Professor Mani, there is another question for you. Some history point for inflammatory disease of the hip joint.
Yeah, come again.
Some history points for inflammatory disease of hip joint.
Okay, inflammatory disease. Now, the inflammatory disease could be guided by what inflammatory disease you're looking at. The one major thing is it is invariably a polyarthralgia or a polyarthritis, meaning that more than one joint is involved. So if it is a bilateral hip disease or a hip pain with maybe a knee pain and a shoulder pain, so one history point is any other joint involved. Other is the type of pain. Now, inflammatory pain is going to be different from a mechanical pain. When you are describing a pain, invariably an examiner asks you, what type of a pain is it? So basically, there could be 3 types of pain. One could be the mechanical pain, the other could be the inflammatory pain, and the third could be the infective pain. So the character of the pain.
Okay.
In infective pain, it could be a throbbing pain. For an inflammatory, it could be a dull aching pain. And for a mechanical pain, it would be stimulated by any movement. So various features in the history would be able to guide you. And one additional factor of morning stiffness gives you a real thump that you're looking at an inflammatory disease.
Okay, thank you, Professor Mani. There is one question we'll take for Dr. Kapoor, Dr. Sudhir Kapoor.
Yes, dear.
Audience wants to know that how to know which pathology is in the, whether the pathology is in the spine or hip in adduction plus scoliosis.
In adduction plus scoliosis.
Yeah, how do you know that it is spine or the hip involvement? Patient has adduction and scoliosis.
Sir, I mean, this is not these are not very separate findings. There will be hundreds of other findings if there is a hip joint disease, and may score of finding the spine disease. Now, if the scoliosis is because of hip joint disease. He's going to have hip joint tenderness. The movements will be restricted, and you will be able to square the pelvis. I think this is more a theoretical than practical.
Okay.
Because, I mean, so many other points will be there. There shouldn't be any basically difficulty in deciding these two.
Okay. And now I'll
Dr.
go to
Manish, Dr.
Yeah,
Dr.
sorry.
Manish, one question, Doctor, my PG wants to know, can we ask one question, Dr.
Fast,
Sudhir,
because
please?
we are running short of time.
Yeah.
Fast question.
Dr. Sudhir, very thanks for nice presentation. Only thing we want to know, my PGs are saying, sir, is there any particular order of examination, whether we should examine the patient in lying down first or standing first, or we can do it randomly, because they get confused when the examiner asks you start the patient presenting.
Sir,
So do we need to?
If you notice, maybe you remember, from the very beginning, I was talking of a sequence, and the very next slide was showing that sequence. We have to go in that particular sequence only: inspection, palpation, movements, measurements. Inspection. I'll just finish the inspection. Means gait, attitude. Inspection in standing. Inspection in standing from the front, from the side, from the back. Inspection in lying down. And then we come to palpation in that particular sequence.
Yeah, and the only confusion is whether we should examine them in standing first or lying down first. That is the only thing, because patient came walking to you in the OPD.
If the patient has come walking to me, it is standing.
Right. That's
Can I add to that?
What is clear?
Yeah.
Dr. Vineet, can I add something?
Yeah.
Yes, please.
Now, this is a known problem that we need to tell gait first or lying down first. So the convention is gait first. However, there are centers which examine lying down first. So the student should be aware that there is another convention also. And if the examiner who is evaluating you wants a different convention, there is nothing wrong about it. And the second point is, if you want to still wriggle out of the situation, you can defend yourself by saying that the convention followed in our institute is gait first, followed by hip. There is nothing wrong about the two ways. Since the patient comes walking in the OPD, you do the gait first. If you are doing the lying down position first, you're actually evaluating an inpatient in a hospital. So the convention is gait first, but even the other way around is not a big disaster.
Okay, thank you, Professor.
Thank you. And doing, Dr. Sudhir, one last thing, sir. Dr. Sudhir.
Yes, dear.
Doing the measurement in involvement of both the limbs, both the hip joints are involved. How do you measure the length? That is a question which the student is asking.
Sir, in that particular situation, when the patient has got bilateral involvement, it is almost impossible for anybody, even for the examiner, to really know. It is just a near about thing. You square one by one and then measure, but nobody on the earth, I don't think there is any known method of accurately measuring the true length if both hips are involved. It becomes very, very difficult.
Okay. Can I add something there?
Thanks. Yes, please.
So the dictum is, if you cannot put both the limbs in a similar position for measuring, you cannot judge the true length.
Correct.
Okay. Can I add something to this question?
I want to say, Dr. Dhawan, regarding the inflammatory and the mechanical pain, the inflammatory pain will invariably decrease with the movement, and the mechanical or degenerative pain would increase with the movement of the patient.
Okay. So I now basically will take questions later on because we are running short of time. So I request Dr. Sumit Sural. Dr. Sumit, please make it by 10 minutes. Just explain about the important.
Sure. So thank you so much. And I'm going to talk about a little bit of the normal gait cycle and then the biomechanics to make you understand how the lurch is on which side, on the affected side. And then I'll talk about a little bit of short limb in towing gait, cane in the opposite hand. If you permit me at this time, then I'll talk about the last two. Otherwise, I'll just stick on to the gait cycle, which starts with the heel strike, then goes onto the foot flat, then is the mid stance, and then the heel off, then the toe off. Then the swing phase starts when the limb is off the ground, starting from the initial swing to the mid swing to the terminal swing. And then the foot again, when it strikes, the heel strikes. That is the finish of the one gait cycle. And one gait cycle consists of 2 steps. So there are other terminologies for this. Instead of heel strike, it is the initial contact. Because, for example, if there's an equinus, the heel will never strike. So it's the initial contact. And what's important is the foot flat. During the foot flat, there's actually a loading response because the body weight is now getting loaded onto the foot ankle, right? And the mid stance is actually where it's a single limb stance where the opposite limb is off the ground. And this is 40% of the gait cycle, right? So during the mid stance, most of the pathologies get revealed, whether it's the Trendelenburg gait, whether it's the antalgic gait, because in the antalgic gait, the patient will not stand on a single limb stance for a long time because it's painful, right? And we look at, as I said, the single limb stance is only 40% of the 60% complete. If you look at the biomechanics to understand hip pathologies and gait, the biomechanics is taken from the physics levers. The first class lever is where the fulcrum is in between. So the load here is the body weight. And you know that this, to make this balance, so the body weight and the body weight lever arm, this product has to balance with the abductor effort, which is created by the forces of the abductor